Welcome to our Arundel County Health Conversations. We started these at the beginning of the COVID-19 pandemic here in the county. This was in March, and the large focus was on answering questions. Things were moving fast, and we wanted to make sure that we had dialogue with the residents of this county so that we can answer questions, understand what the issues were that you were thinking about, and have that conversation going. As we've been going along, we'd like to get in depth with some of these issues that we're talking about. And so we're switching our format a little bit. We're going to be having a conversation today with Dr. Boris Lushniak. Dr. Lushniak is the Dean of the University of Maryland School of Public Health, and he's been that since 2017. He's overseen the development of several new academic programs, launched a global health initiative to build and expand education, research, and service activities aimed at improving health across the globe, and has prioritized public health action for civic engagement around issues such as preventing gun violence. Dr. Lushniak served as an officer in the U.S. Public Health Service Commissioned Corps for 27 years, culminating in roles as U.S. Deputy Surgeon General from 2010 to 2015, and Acting Surgeon General from 2013 to 14. During the 2015 Ebola epidemic, he commanded the USPHS Monrovia Medical Unit in Liberia. He orchestrated the release of the 50th anniversary Surgeon General's Report on Smoking and Health and the first ever Surgeon General's Call to Action to prevent skin cancer. He earned degrees from Northwestern, both his bachelor's and medical degree, and from Harvard University for his Master of Public Health. He currently serves on the Board of Regents for the American College of Preventive Medicine. Welcome.
Hey, Nilesh, it's a great opportunity to speak with you and a great opportunity to reach out to the people of Anne Arundel County and talk a little bit about this incredible and devastating situation that we have with COVID-19.
Yeah, it's really good to have you with us, Boris.
Right.
I really wanted to get your perspective from a larger framework. I think we've all been kind of really hunkered down with what's going on right now, and I wanted to expand that a little bit and just hear your thoughts on previous pandemics. Tell us a little bit more about some times that we've seen pandemics in the past.
It's interesting. So let's go out sort of with the basics of what a pandemic really is, right? A pandemic is a worldwide epidemic, and an epidemic is an increase beyond the normal of a disease, right? Oftentimes we think of it as an infectious disease, and we'll talk about that in this realm. When we look at pandemics, there's really three key features that have always been part of a pandemic in the history of mankind, of humankind. And that's point number one is usually we see a brand new virus appearing from nowhere. We call it a novel virus, just like we have, what's called SARS-CoV-2 is the name of the virus associated with the disease COVID-19. So it's brand new, meaning that it's always a sense of uncertainty in terms of how we're going to react to it because the human body has never seen this before. The second aspect of any pandemic is what? Besides having the novel virus appearing, and that usually comes from the animal world, we also have the ability to have it transmitted from person to person. That's the second key feature of a pandemic. So it's not just from an animal to human, but it becomes transmissible between Nilesh, you and me if we are in contact with each other. And the third feature of a pandemic is that it causes serious disease, right? That it's not something that just sort of dwindles out there or causes no problems whatsoever. So those are the three components of a pandemic. And historically, we go back into the 20th century and we kind of know that pandemics have been occurring intermittently. They've never been coronavirus, so this is brand new. They've always been an influenza, a flu virus in the past. And perhaps the one that was most devastating, that we do a lot of comparisons between COVID-19 and the influenza pandemic of the year 2018 and 2019. So 100 years ago, right? That sometimes is incorrectly termed the Spanish influenza. It really didn't start in Spain. It probably actually might have started here in the United States. But, all that aside, historically, if you look it up, sometimes it's called the Great Spanish Flu or the Great Influenza of 18 and 19. Beyond that, though, we had two other pandemics in the 20th century, one in 57 and 58, and another one in 68 and 69. Always influenza, always brand new influenza strains coming to us. and always with that same pattern, right, of spread between humans and causing serious illness. We actually had one other pandemic in this century, and again, 10 years ago in 2009, we had something that was called swine flu, H1N1, and that turned out to be a pandemic. In comparison with this pandemic, that one was relatively mild. It still met the definition of a pandemic. It started actually in 2009. It started on the California-Mexico border. That was the first case, and it spread throughout the world, ultimately infecting probably millions of people across the world, probably 500,000 deaths across the world. In the United States, we had 1 million cases between its first appearance, which was April 15th of 2009, and by July, we had over 1 million people infected. Sort of, a similar type pattern as we're seeing now. The big difference, though, is for that total pandemic of 2009, 2010, we only had roughly 12,500 deaths. And it's not that deaths, any death from infectious disease to us public health people is one too many. But on a relative scale, we know that COVID-19 is much more deadly. We compare it to 2000 or to the pandemic of 1918, 1919, where looking back at the information back then, there was probably over 675,000 deaths in the United States from that pandemic, which was influenza, and worldwide, maybe even upwards of 50 million people died from that pandemic. So pandemics have been with us throughout history, always scary, always uncertain in terms of how we're going to deal with them, but we always deal with them. And I think, being in the, just like you, Nilesh, as a public health guy, I always say, you and me and public health people have to be optimists. We have to always say, here's what we know, here's what we don't know, and here's how we're going to find out what we don't know and solve this problem.
Yeah, I think that's a really good point. And I'm actually, one of the things that I think is really interesting is that we're learning in real time, and the public is learning with us, which is not how things usually go, right?
Well, yeah, we'd like to almost think that we as scientists have it all, right? That we have all this knowledge. I'll tell you what even the pandemic of 2009, I was in a different, I was in a position at the US government at that time with the Food and Drug Administration, running an office called the Office of Counterterrorism and Emerging Threats. So that was a good chunk of my job 10 years ago. Even back then, it's almost what we're experiencing right now. There's a case of a sense of humility in the sciences. Don't forget, I'll remind our viewers out there today that the first time we found out about this was on New Year's Eve, right? This is, and it seems now like it's years ago, right? Based upon what you and I have been experiencing, what our public has been experiencing. But it was New Year's Eve. And what happened on New Year's Eve of 2019? As we were all preparing to celebrate the new year coming on, the World Health Organization office in China was informed of a series of patients, of people who had unexplained pneumonias, unexplained cause. And that was the first time the world started finding out about this. So we're relatively early into this, right? I mean, do the counting, right? Between January and now, it's, 5.5 months or so that we're sort of knowing about this. And you're absolutely right. We keep learning things all the time.
So how do we take the lessons learned from previous pandemics and sort of marry that to take those lessons learned, but also recognize that we don't know everything about this particular pandemic and mesh those two together to make some sort of sense of what's going on now?
Yeah, and it's interesting. We start off with the basics of public health, and people will always say, well, where's that treatment, right? Where's that medication? Where's the science? Where's the vaccine? Well, people, it's happening, right? There is research going on, and my hope is we get a treatment. My hope is we get a vaccine. But there's uncertainty in that medical science and that public health science for us to achieve that. Our hope it's going to happen, but it's not happening right now, right? We're not going to get that result tomorrow in terms of a treatment, a pill that we take, and we're not going to get a shot 2 days from now that's going to solve this whole problem. And what we learned from past pandemics is what we sometimes use. I never like the term, but it's called the non-pharmaceutical interventions. It's basically what public health tells people, saying, okay, here's what I know about the disease here and now. Right? I'm learning every day. And so people understand, I may be a little bit wrong on some of this, and I may have to change my mind, with more information coming in. But the common thread is what? If it's transmissible from person to person, which we know COVID-19 is, and we know what's called the route of transmission, right? Which is how do you get it from me and I get it from you? It's from me potentially coughing or sneezing or even breathing in your direction. And if the virus is in me, it sort of goes through, right, to you, or me touching your hand, right, with a hand that has the virus and you touching your face. So it's done through that route. So the non-pharmaceutical interventions really start with almost the same thing we did 100 years ago, believe it or not, during the 1918 flu, which is we told people, stay away from each other, right? This whole idea of physical distancing, and I prefer the term physical distancing. The social distancing aspect means that you and I aren't friends anymore. Socially, we have to stay away. No, you and I could be buddies and we can have family members that we, are living in different households. We can still have a social connectiveness, but the key is physical distancing. And so we learned from our past, and from our past, what worked in the past? Well, physical distancing played a key role. Not congregating in big groups played a key role. There were major mistakes made 100 years ago in the 1918, 1919 influenza. And one of them was comparing sort of the responses of two cities. This is almost a classic historical piece of public health, right? It's October of 1918. And what's happening then is we have, two different cities. St. Louis is one and Philadelphia is the other, and they're reacting very differently. St. Louis, who actually had very few cases of the influenza at that time, basically told his people, listen, no congregation of people, no mass gatherings, stay away from each other. Philadelphia threw a big parade. It was a parade for war bonds. It was to raise money for World War I. It was deemed, okay, this is necessary. And what we saw was an incredible spike of the number of people infected in Philadelphia and a real leveling off. Remember that term that we've been using for months now was, flatten the curve. Well, that comes from that whole thing. So it's those basic things of physical distancing. And then the other basic things is if I know that one of the routes of transmission are my hands, I go back to what I told people 100 years ago. I wasn't around, you weren't around, but what public health told people. And that was keep your hands clean, wash them often, right? Beware of how you cough and sneeze, do hygienic methods, right, with all that. We go back to those basics, and those basics, if done correctly, allow us to make sure that this thing doesn't blow up too big, and that it buys us the time to be able to get those vaccines or those therapies on board. And so, we learned from the past pandemics of what worked and what didn't work, and that's what we're applying now.
Yeah. So on that idea, different countries are, we hear reports from different countries, and they're very short, newspaper articles or whatever, but what countries are doing well and how are they doing that?
Well, you look at some of the examples. I mean, one of the countries that stood out early on is South Korea, right? And everybody's trying to kind of look at the South Korean model. And partly it is because what? They started testing really quickly, right? And I'm sure our viewers have heard about this, the issue of testing here in the United States. We started slow. We had a problem. Everyone's admitting to it, right? The test that was put out there wasn't working well. It's taken us a long time to catch up. And what South Korea did was right off the bat, they started testing a whole lot of people. And testing isn't just for testing's sake, right? It's not enough to just say, I'm going to test you, and therefore I'm going to tell you whether you're positive or negative. It's the public health response to that positive or negative person, right? And what happened in South Korea was a really sort of concentrated system was if you were positive, you were really sort of given the directions about isolating from others. You were kind of taken care of in that process. And then the whole idea of if I'm a positive, and people have heard of this as well, is the whole idea of tracing, contact tracing. So it's testing, it's tracing the people that I've come in contact with in the previous 14 days. And you know how hard that can be. I'll ask our viewers today to basically try to figure out, right? It may be easier now that we've all been staying at home, but who have you come in contact with in the last 14 days, right? And that's the goal of the success of South Korea was that they started testing, they started tracing, and then the third component was the isolating for people who are positives or the quarantining of people who may have come in contact with a positive, right? this whole stage of epidemic control is the term, people may have heard of this in the press, it's called the containment stage, right? It really is that we're almost, think of it almost as a battle, as a war. The virus is the enemy. How do we separate out the virus and how do we make sure it no longer exists? And part of it is because it's person-to-person transmitted, I got to figure out a way to make sure that I know who has the virus in them and I take care of them. Where needed, I'll treat them, right? There's more, the people who are more ill go to hospitals. And yes, we have to throw in the idea that public health is caring. So we put our hearts out to everyone out there who has suffered illness in their family or perhaps death in their family. But at the same time, that's part of the public health approach. Treat the individuals that need to be treated, isolate and quarantine the others so that we ultimately can stop this virus from spreading.
So one of the things that I think about is, so when we're doing this contact tracing, that isolation, quarantine, there are costs to that, and we hear more and more about the costs to doing that. Mm-hmm. So what are the trade-offs as we have as we're doing this that we need to be considering?
I certainly, everyone is devastated by the economic costs of something like this. And maybe some of us are, in fact, somewhat surprised of how quickly things started, happening on the economic front. And it just shows you that our society, unfortunately, is based on many people who live paycheck to paycheck. Many people who, whose jobs are dependent on the categories of jobs that all of a sudden were being closed down. So, it gives us a bigger reflection of our society in general, right? But, the trade-offs really are this, is what's critical for our society. And I always viewed it, you mentioned in my, in the kind intro you gave me that I spent 5 years in the office of the US Surgeon General. And what became apparent to me in that office was several things. Is first of all, I'm a strong believer of the definition of health that the World Health Organization puts out, right? And I'll ask people to contemplate. I'll say it slowly, and I want you to contemplate each and every word. Because health is what? Health is complete. It's not just partial. It's not like I'm almost there. It's complete. So there's a aspirational, there's a wishing for completeness, but it's complete, physical, mental, and social well-being, and not merely the absence of disease or infirmity. So if I'm a believer in that definition of health, it's not just the physical. It's not just having this idea, do I have a virus or not? Do I have a fever or not? Am I in an intensive care unit or not? That's a key component. But also the mental health aspects of this, right? And the repercussions of that, the anxiety, the depression, the uncertainty that grows with that. But the third factor is just as important, which is social well-being. And in social well-being is my economic well-being. It's the idea of whether I have a job or not. It's a matter of whether I have insurance or not, whether I'm surrounded by my loved ones or not. Those three things are not independent of each other. But in the midst of that, when I'm dealing with something that first and foremost is causing a physical harm to our nation, to our people, to the county and Arundel County, that's what I need to be dealing with as a first component, understanding that they're interlacing, right? COVID-19 is not going to go away on its own. And if we let it sort of just be out there, it will kill more people and it will sicken more people, and we'll have even more repercussions on the mental health and on the social health realm. So we have to kind of take into account these decisions for public health people, as Nilesh, that they're never easy. We make decisions that do affect people, but ultimately we have to be dedicated to the health and safety of our society. And that's a key component in this decision making.
Yeah, I want to dig into that for a little bit, because I think that there's an interesting space here, which is those trade-offs in economics, in mental health. The trade-offs from, okay, let's do these widespread efforts to create physical distancing, stay at home, and they have costs, right? People can't go to work, they don't have jobs. It creates a lot of anxiety. People are they feel socially disconnected. But the alternative is we resume, and then there's the costs of illness and death, and that psychic toll that it has that toll on the economy as well. How do you think about balancing those things? There's no right answer, obviously, but I'm just curious about your thought process.
Yeah, I think we have to, part of our job is actually telling people about the difficulty of these decisions, right? I mean, I think of being honest. And the idea is that, as I mentioned, what are the alternatives to some extent? And the alternatives have to be discussed. I'm a physician, right? By training, I'm a public health person. And ultimately, my goal is to make sure that people are healthy, right? That they bounce back from illness and that they don't spread illness to others. I believe that the approach on this is that, and this is something in those 5 years that I mentioned in the Office of the Surgeon General, I always pushed all the time, that the economic strength of our country doesn't happen unless we have a healthy workforce, unless we have a healthy people. That being unhealthy costs our society all the time. And that's not just COVID-19. That's the other problems that all of us are dealing with, that you're dealing with in Arundel County, is the issue of diabetes. Diabetes has a cost, right? And my sense is that we have to be able to work on all fronts. It's not easy, but how do I really sort of look at the idea of health being, and I used to say this all the time when I was in uniform as the acting Surgeon General, is health is an important and a critical national natural resource. And oftentimes we don't treat it as that. We almost think of it, health is, well, it's kind of optional. It isn't optional. If we really want to be a strong society, then I have to put a lot of credence in making sure that society is healthy. But it's not an easy thing, because oftentimes even the decisions that you've been making in your capacity, that I've been making at the University of Maryland in College Park, in consultation with the leadership there, that, the governor has been making with his consultants, that the president's been making, all these have repercussions. It's never a simple approach saying, well, here's the right answer, and here's the one that's not going to affect society in general. But in the midst of a pandemic, the only thing we're going to stop this thing is by doing the right thing, right? Stopping its spread. Otherwise, it's going to continue to sicken people, and it's going to continue to kill people.
Yeah. I want to touch on something you said, which is about health being a core part of our society. And one of the things that I'm not going to tell you that I'm surprised about is the disparities that we see in some of the measures we look at when we look at COVID. I can tell you in our county, we see that the Hispanics are positive at a rate about 3 or 4 times higher than we would expect based on demographics. We see a death rate in Blacks that's about 50% higher than we would expect in terms of demographics. And I'm curious as to your thoughts about not just how we got here, but also how do we use that information to inform our care around COVID?
Well, we have to react to that. And it is sort of, it's interesting at the School of Public Health, University of Maryland, we have a whole center run by an excellent faculty member, Dr. Stephen Thomas, called the Maryland Center for Health Equity. And to a large extent, that center's been looking at this issue all along, right? Which is when we talk about, right, the communities of the underrepresented, communities out there, the minority communities, the communities of color, the communities of immigrants, right? We have various labels for them, but a common thread is those are communities that we have to now, once again, reminded with all the data, right, that's coming out of COVID-19. That word data is so sterile, right? What we're talking about is people are dying and people are sick at higher rates. And there's several things that we know is the cause of that. Part of that is that we are not supporting those populations well. That there may be issues of access to medical care. There may be issues of health information and health literacy. We have another center at the school called the Horowitz Center for Health Literacy. It's all about the idea of how people interpret the idea of medical care. So is that part of the issue? Is it the sense that I, as an outsider, don't understand that community and that community has distrust in me? That's part of the formula also, right? So part of this is, one, we can't ignore this. And I'm glad you're not ignoring this by any means at the county level. And that we have to begin to understand, one, how do we solve the problem right now, right? Because people are going to continue to die and to be sickened unless I do something about that, which is I have to understand the communities that exist around me. And I have to now view them as high-risk communities, which means I'm going to push into that community harder and begin to understand who are the trusted information sources for those communities, right? That's one of the approaches we need to be taking. But at the same time, let us learn a lesson. You know, the interesting scenario, and I was telling this to our students who, by the way, are graduating today virtually from the University of Maryland. It's a tough way to be said, you know, to sort of start off this next phase of their careers. But we have to look at this COVID-19 as, first of all, let's acknowledge it's nothing that you and I ever wished on our society, right? We never wanted this to happen. That's point number one. Point number two, now that it's happened, how do we learn from this? How do we learn about our people, right, in the county? How do we learn about our people at the state? How do I learn about my students and my faculty and the staff? And how do I ultimately make things better, right? And I think when it comes to the issue of health equity, health disparities in our community, you and I have now even a bolder mission to undertake, because those numbers are right before our very eyes, and those numbers are real people.
Yeah. You know, one of the things I think about is, and you know, I'll draw a parallel to the healthcare side of things, is that we have this large block of work that we do that's geared to get as many people as possible. And health equity is really looking at who are the people who need more assistance, because we see that they are disproportionately impacted. And I think a lot about how do we get that workforce, that body of knowledge, woven into the work that we do, so that it's not really health equity anymore, but it's just we target our resources to where they need to be. Maybe that's a little bit pie in the sky, but I'm just kind of curious about that.
But no, I think that's a great approach, right? I mean, part of it is, you know, and you know, I've used the word data several times already, but we have to be a data-driven science in public health, right? We're always going to have emotions, and public health is a caring science. We care about people. We have to love people. That's part of what we do in public health, right? But in the midst of all that, we have to define where our problems are. And you know, to some extent, we have to be able to say is where in my community, I mean, you have a job, right? You have a job for the good of your county. You have to determine where in that county are my issues regarding the health and welfare of that county, right? That's your area of jurisdiction. So you look at it, I think, from exactly that point of view, is start off with information, which is what are my problems? What are the diseases that are killing people, right? You know, right now it may be COVID, but you know, when COVID goes away, it's going to be something else, right? And ultimately you begin tackling it from that perspective, right? Because the idea is that our job in public health, and I remind my students all the time, I simplify public health, and I always say, you know, it's based upon the 3 Ps, as I call it. It's about preventing disease and injury. It's about promoting health, wellness, and well-being, with the ultimate goal of prolonging a high quality of life. And we take that definition, which still is a bold and noble calling. There's a lot of work to be done. But if we begin to sort of look at the world around us, is where is that disease and injury I need to prevent? And how do I promote the health and well-being? And how do I prolong a high quality of life? It's not just the number of years, it's the quality of that life. I now have a tasking that can be undertaken, right? We look at my communities very differently.
Yeah. And I think that's a really good point of, you know, what's our goal? Our goal is to do exactly that, to prevent, promote, and prolong. And, you know, to that end, I want to pivot a little bit and talk a little bit about vaccines. I know that's a topic that's out there a lot. It's one of our key public health measures, and I feel like certainly maybe not in the past few months, but in the past many years, we've been defending the role of vaccines in public health. And so it's really interesting to hear now this clamor for a vaccine, and wanted to get your thoughts on what that process looks like and what that might mean for COVID in the longer run.
Yeah, and I think, you know, first of all, let me sort of start with that general approach. I mean, vaccines are a public health victory, right? I mean, you know, when you look at the idea of 100 years ago, okay, so remember we started talking about the 1918-1919 flu, right? How many FDA approved vaccines existed on this planet, right, in 1918, 1919? The answer is zero. First of all, that's a trick question because the FDA didn't exist. But the reality was that our science had really limited understanding of disease, about infectious disease, about transmissibility, and limited information about our immune system. And what we did in the course of the 20th century was we started vaccination programs. They remain controversial to this day because there are, people in our society who believe that they are harmful. Let me tell you the facts, right? The fact was that we used to have a killer on this planet, and the disease was called smallpox. And it was ravaging throughout most of the planet, right? The United States had a last case in the 40s or 50s, right? But now we're recently commemorating the 40th anniversary of the elimination of smallpox. The whole virus has been eliminated off this planet because of a vaccine program. And now we no longer even get the vaccine, right? We have it in stockpiles in case it ever somehow comes back. It's stored in labs, but it doesn't even exist on this planet. So we took a major killer, and using the immune system and vaccines, we basically got rid of it. We're very close on polio. Polio, if you look at the history of polio, right? Summers in the 40s and 50s where people, young kids, right? Part of the source of transmissibility is through water sources, right? The whole idea of swimming in a lake was dangerous. And afterwards, you had severe breathing problems and perhaps paralysis, the term iron lung, where people were put into these machines so that they can breathe. And this wasn't just for a few days. This was weeks, months, and years, right? And now we've had a vaccine program that is near eliminating it. Unfortunately, it's been near eliminating it now for many years because there's parts of the world where it's become very difficult to try to eliminate it. So vaccines are a key component. And first thing I want to tell everybody out there is that we already have information coming in that because of COVID-19 and because of lack of access to pediatricians' offices and all that, here's the plug for vaccines. If you've not been vaccinated or your kid hasn't been vaccinated, make sure you get back on the schedule, because things like measles, we're worried about coming back because of under vaccination in the midst of this pandemic. But now what we do is we have this history of vaccines. Now we talk about COVID-19 and the vaccine. And, the reality is one real nice way of dealing with this, and we did this 10 years ago with influenza, was we try to develop a vaccine. And we try then to give it to as many people as possible, and that we allow our immune system to then say, oh, the minute that I get this virus in me, I know how to fight it. Remember, we were talking earlier about the definition of pandemic, and part of the key definition is it's novel. So my body has never seen it. So how can I fake my body to say I can figure out a way to fight it off? Now, 10 years ago, we were able to get a vaccine. I mentioned April 15th was the first case of H1N1 of influenza. By that winter, right, between April and November, December, we had 4 and at some point 5 different vaccines that were approved by the FDA, and we started having a vaccine program. Why did it happen that quickly back then? Well, we were dealing with influenza, and we've actually had a whole history of influenza vaccines, right? Make sure, to your viewers out there, get your flu shot in the fall when they're available, a key feature, right? But we're good. We're good at influenza, right? The problem with COVID-19 is, one, we've never, ever made a coronavirus vaccine. Right. And I'm going to remind people that this isn't the first coronavirus we've seen. This is the 7th that we've seen. There's 4 coronaviruses that cause cold symptoms. They've been around for a long time. There's 2 new ones that have appeared just this century, right? One that caused a disease called SARS and one caused a disease called MERS, right? Brand new ones came out of nowhere. Now we have the 3rd brand new one. But against none of those do we have a successful vaccine. So what our backs are up against the wall on this is that we learn from influenza of how the different technologies are out there to make vaccines. Right now, there's out there, they say there's 100 different ones being looked at right now, right? So the whole world is doing this. My enthusiasm for this is actually heightened. And I mentioned, in public health, we have to be optimists. Pessimists wash out really early in one's public health career. But in the middle of all that is what? Is that, we have all these studies going on, and we're looking for that one or two or three or four or five that are going to be successful, right? Our hope is there's going to be multiple ones that are going to be successful. But we're starting this research, and my optimism stems from the idea of compare it to what we were talking about 100 years ago, right? We had a huge pandemic from influenza 100 years ago, and the science and the understanding has evolved incredibly. We've never in humankind's history ever been at this point in time. A bad pandemic and science at this highest level. And those things combined will ultimately lead us down a pathway. Now, the big question always is, well, how long it's going to take? Well, it's not going to be as quick as it was for influenza. As I told you, we had a whole lot of experience for influenza. We had a pathway, and we knew it was just changing the type of influenza virus in there. And then ultimately, we had factories that knew how to make the vaccine. Here, we're starting with science right now, with research and development, right? And we're going to look for the successful ones. And then at some point, you have to keep testing these in more and more people, because the last thing you want is, one, something that doesn't work. So you have to prove it's going to work. And then secondly, you don't want to have something out there that's unsafe. So you have to prove its safety. And then you're going to have to build the factories or assign factories and systems to be able to get the vaccine out. And then you're going to have to distribute it to the world. So the vaccine, I think, will come. I'm an optimist on that. We've always been told it's 12 to 18 months away. We've had some recent good news just this past week on the vaccine front, in terms of some good results. And the hope is that this will continue. But don't forget, we've never been here before. And there's a lot of research that still needs to be done.
Yeah. Yeah, I think that's a good point. And I'm going to tee you up for a softball. How important is it to get the flu vaccine this fall?
It's going to be probably the most important season that you and I have ever seen. Partly the reason is that, and people probably already know this, that the symptoms that we associate with COVID-19, with the pandemic, are not that different from what we see with the seasonal influenza. Mm-hmm. The obvious thing I can tell you is we will have a flu season. Why am I that certain? Because we've had one every single year since you and I were born, right? Mm-hmm. And for hundreds of years probably before that. So the idea is that every year we know, right, that there's going to be flu coming here. In fact, already now, right, our public health system is out there monitoring the flu viruses that are existing in Asia, in Australia, because that's there's a pattern to where the flu is coming from. And they're going to start concocting 3 or 4 different types of flu that's going to be the next vaccine. And I'll admit to you, people say, oh, it doesn't work. Well, some years we have good years where we predicted the right ones, some years less good years. But even a bad year, right, with prediction, it's still been sort of focused on the idea is that vaccine still to a large extent works. It may not stop you from getting the flu, but may make the symptoms much lighter. So you got to look at it is that, first of all, get the flu vaccine. Secondly, because the flu vaccine will protect you from flu, that'll help us with sort of distinguishing what we're hoping doesn't happen, but we're starting to talk about it. And that's a second surge of COVID-19. And when we look at what we know, and why do we talk about this COVID-19 second surge? Because guess what? Every influenza pandemic that we've ever seen has always had 2 surges. So we're kind of saying historically, this is what happened. And happened in 1918, 1919, and it happened in 2009 and 2010, right? So we know there's a double curve. And what I want to tell people out there is get your flu vaccine when it's available in the fall, because I want to protect you from that. And then if you get sick, not when you get sick, if you get sick, then we can sort of get a better sense of what that fever is really being caused by, right? And if it's COVID come back, hopefully then we'll be able to deal with it much more easily.
Yeah, I think that brings up a really important point about public health, which is that it's a series of actions that we take that will increase our chances of doing better and increases chances of others doing better, but it doesn't have that one-to-one. So it loses some of that visceral, this will help me, this won't help me, kind of that duality of it.
Right.
And how do you talk about that? How do you convey that idea of percentages and risk reduction and, the things we talk about technically, but
yeah, it's almost like you have to delve into, there's a saying that says, and it goes back to this whole idea. Part of what we're trying to do here is prevent, right? It's that T, that first P, right? Prevent disease and injury. There's an old saying that, I don't even know who would have coined it, but, you heard it all the time, probably. It says, when prevention works, nothing happens.
Yes.
And when you look at it, you realize, well, that's exactly it. Because if I'm preventing something, I'm never going to see the result of it. I prevented skin cancer. I prevented lung cancer, right? And the reality is that when we're focused on prevention, the success story doesn't come at you and punch you in the nose. It doesn't say, look at me. We have to dig deeply and sort of look at it from the perspective of saying, okay, if I prevented something, how do I allow my community to celebrate in that prevention? How do I even talk about the good it brought to that community, the money we saved, the lives we've saved, the families we've kept together? And I think what we in public health have to do is get better at that, get better at measuring our successes, right? And say, look at what's happened, right? You don't see it because it's easier to sort of look illness in the eye or look death in the eye and say, oh my God, that's terrible. But if I prevented that illness or I prevented that death, people tend not to notice. Nothing happens, right? Nothing happened. So therefore, with the double sort of meaning of that statement that nothing happens, it means also nobody celebrates it. And it means that the job you and I do sometimes is not given the right sort of perspective, right? And importance to our society. It's given like, oh yeah, that's, nothing happens, so who cares? Well, I think we have to almost say nothing happened, so the world should care about that because we've just done some good. So I think when it comes to the percentages and all that is, let's just make it. The sense is, what good are we bringing to the world? By preventing COVID-19, right? What good have we brought it? And how can we at least let our viewers know about it? We prevented disease, we prevented death, and that's the job that we're trying to do here.
Yeah, and I think that gets to the idea of the story, right? When we tell the story of it, if you project backwards, nothing was going to happen either. And I think that's where we get stuck. And I love the idea of celebrating that prevention and telling that story of what it could have looked like and what it has looked like in the past. Right? This is not just theoretical.
Right.
We are dealing with things that we are now trying to address and prevent from happening.
And to some extent, our battle really right now is only beginning when it comes to public health. And let's just talk about at the Arundel County level, right? The issue right now is that, people are noticing us right now and noticing your great work because we're in the midst of a crisis. I'll keep reminding people that when COVID-19 goes away, and it will at some point go away, we will figure out how to deal with this. It's not like your job becomes less important, right? What's in essence happens is that people have to realize that this prevention aspect, as I talked about earlier, right? We just changed the disease and it may not be in the news every night. And the president and the governor may not be talking about it every day. But there's a lot of work to be done for the good of the health and safety of our population. And that continues. And I think our struggle is to make sure that people don't just say, oh, public health, thanks for being there in the midst of crisis. But now that the crisis is over, who cares? No, we got to be able to now use this as a jumping off point and say to people, listen, right now we're telling you to do the physical distancing, to wear a mask, to wash your hands. But, hopefully a year or two from now, I'm going to tell you to eat better, exercise, and, take care of your high blood pressure, right? I mean, those are the things that we focus on. The goal is still the same. I want to prevent death and I want to prevent illness.
Yeah. So thinking about that, what does the future look like? What do the next few months look like? What do the next few years look like for us?
Well, we're at an interesting stage, and you're at it at the county level, at the state level. I'm at it at the university level, right? I mean, my background here is the School of Public Health, right? And this picture was taken when, the picture was taken, when I had a few students hanging out there and the place was filled, right? So my goal is similar to your goal. I want this place to be active and filled up again. I want it to be an educational institution. You want to make sure the people of Anne Arundel County are heading back to work, to school, enjoying the recreational options out there. And where we're at right now is a very dangerous time, but an important time. And that's, sort of the reopening of things, right? We already know the statistics. All 50 states are reopening to some extent. Some are happening at different levels. I'm proud of what we've done in Maryland here in that, we've been looking at the information in front of us. Have we seen decreases? And we really are taking a phased approach to this. So I think the correct way of doing this is exactly this, is follow what's going on in our communities, right? So if the number of people diagnosed is heading in the right direction, if the number of hospitalizations and people in the ICUs and deaths are heading in the right direction, that gives me a sense of not that it's over, but it gives me a sense as, okay, maybe we're heading right into the right pattern here. And once the right pattern is happening, then I begin slowly to open up our world, right? And it's a phased approach. It's not an on-off switch. What it is, okay, what's going to be least risky, right, for us to do? I like the way, here in Maryland, we're using the term, right? It went from the stay-at-home orders to the safer at-home philosophy. So it's still safer to be at home, right? But when I do go out, here's the things we're recommending. So I'm seeing over the next several months is that if we do this right and we see these patterns of decreases, that we'll start reopening things that are now closed. And that ultimately our life turns into more like it was before. Will it ever go back to what it was like before? I don't know. Maybe we don't even want to go back to where we report to some extent. I want everybody to be employed. I want everybody to be back at school. But we may have certain customs that we're going to have to take on. This idea of a huge number of gatherings taking place. Well, I don't want our stadiums and our beaches and our amusement parks, everything out there to be completely filled with people until I feel that that's a safe environment. So those are the types of things that are going to take us a little longer to open up, these mass gatherings of people, the huge festivals and celebrations. But that doesn't stop me at some point to say, I want to take a walk in the park. I'm going to be wary, right? That's happening right now. I want to spend time at the beach as long as I'm not hanging around with a ton of people, right? We're going to take these steps-by-steps approaches, and that's going to be the next few months and perhaps even the next few years, right? Which is as we sort of readjust to this. Because again, we've never dealt with COVID-19 as a disease. We never dealt with this virus before. So it's hard to predict exactly what's going to happen. But what we're trying to do is prevent sort of the unknown from taking place. So it's going to take further readjustments for us.
Yeah, and I think that's a really good point, which is that it's hard, and we've seen this as counties open up, cities open up. It's just this sort of rush out, this release of energy. People who want to get back to the old. And how do people readjust to the idea that there isn't an old anymore? Not in the way that we knew it exactly.
Yeah, I think, and part of it is the whole issue of the importance of us getting the information out. And I can't emphasize enough, it's really sort of public health communication, public health education, and taking into account the idea of public health literacy, right? So if I'm speaking, am I actually speaking in terms that people understand me? Do people understand the repercussions and the potential problems of being ill, of being severely ill for something like this, right? And do they understand that the world can still be reopened, but that you need to be careful, right? So I think a lot of it is the burden on you and me and other public health personnel, your staff that's doing an incredible job out there. By the way, I saw the Washington Post article about Arundel County today in terms of contact tracing. Great job to you and your whole team. But to a large extent, it takes that level of making sure that the community understands what we're dealing with here. That most importantly, we're not being malicious. We're not being over cautious. What we're trying to do is we're trying to keep people safe. And I go back to the concept I told you earlier, that public health is a caring and loving profession, right? And I think we have to show more of that, saying, I understand, but it's about your health. So these things aren't going to be easy, and it takes sort of a cultural shift for us to accept them.
Yeah. Well, listen, I really want to thank you. I really enjoyed this hour to be able to spend with you and just get your perspective on this moment in history, really. We are living through a moment.
Well, I think that's an important part of this. I go back to what I said a little while ago. You and I didn't choose this, But really, even at the individual level, you know, I've been sort of here in my homestead with my two daughters, college-age daughter and my daughters and my wife. And, you know, sometimes it's easy, sometimes it's harder. You know, we're all trying to get our work done. We're trying to sort of take care of people around us. But also at the same time is how do we look at this as a learning experience for us all? What am I learning about myself as an individual? What am I learning about my family? What am I learning about my community? I think, you know, this gives us an opportunity to grow, you know, in the midst of what is a tragic scenario.
Yeah, I agree with that. It's an opportunity for us to grow and learn and to care.
Yeah.
And so thank you. I want to thank you, Dr. Boris Lushniak,
Great.
For joining us today in our series of conversations. And you know, I'm a huge fan of the work that you're doing. I've certainly enjoyed the conversations with you, but also with other faculty at the University of Maryland School of Public Health. I'm really looking forward to the collaborations that are coming from just our beginning discussion so far in the past few months. So thank you for all of the work that you're doing.
Well, thank you, and keep up the great work in Arundel there.
Thank you. Take care.
Bye-bye.